We'd like everyone for joining today's webinar on Behavior Supports Rule Part 1. I'm Heike Johns, Learning Development Coordinator for the Division of Developmental Disabilities, and I will be your host for today's webinar. First, I'd like to share that participants are muted upon entry, however, we still suggest that you mute your line. Just you have the ability to control your viewing of the presentation via the navigation tools on the top right of your screen. If you have questions regarding the content being presented, I ask that you present those questions in the Q&A box. If you have questions regarding sound and other technical pieces, if you'll please put those in the chat box. We have this presentation, the recording converted and packaged up, available for review. We will send out an email blast through the division email. If you're not signed up to receive the division email blast, you can do so by going to the DD website. On the right of the screen, you'll see a yellow box that says Get Email Updates. Click there, it'll take you to a registration page. On the completion of the webinar, there will be a brief survey open in your current window. We encourage you to please participate in the survey, as your feedback is important to us. Now I'll turn it over to today's presenter, Dr. Terry Rogers, Chief Behavior Analyst for the Division of Developmental Disabilities.
Everyone, I hope that you're because you want to learn about the behavior support rule and the draft directive, and more importantly that you want to learn how or learn what is expected in terms of having positive and least restrictive strategies, both in the individual support plan and in any behavior support plans. So today in part 1, we're going to be reviewing some of the elements of the directive and the draft rule. My Vanna was distracted, so next slide. The objectives of this training, both part 1 and part 2, are to review some of the major elements of the directive, including reactive strategies, restrict strategies and rights restrictions, timeout and chemical restraints. Also to review the expectations for planning teams, the behavior analyst, and the regional offices around the directive, to discuss some examples of some of these elements that have been confusing, inform everyone about prohibited practices, to role and function of the regional behavior support review committees, provide information about the special review process that will take place if restrictive or prohibitive practices are discovered, and also to remind everyone of the requirements for the home and community-based services rule that all of our services have to comply with. So, you of is that I'm to be talking to you about the rule and about the directive. How I strongly recommend that you all also read these things for yourselves. So don't take somebody else's word for it. Read it for yourself. You should always do that. This is the relationship of the directive to the draft behavior supports rule. Now, and has been for since May or so in the revised format, and is applicable to all people who are providing services in our system. So it's not just for the regional offices, it's also for providers. The director, Val Hune, has said this because we are in the process of promulgating a rule. However, until that rule is in place, the directive will serve. So, I think that's everything about that. Just a reminder for you all. What is the home and community-based setting rule, and what does it have to do with behavior supports? Well, the home and community-based setting rule applies to everything that we do. So it especially applies to Medicaid waiver services and to the rules that we follow within division, within providers, anyone who's providing supports or receiving supports through Medicaid waiver. just some reminders about what that, in case you were on an airplane that disappeared for 5 years, but when you landed, it seemed no time at all. You know, that show that's on TV. In case you were there and you haven't heard about the Home and Community-Based Settings Rule, let me remind you or review some of the requirements for you. All settings, which in this rule the federal government is considering settings to be services, must ensure the following things: that there's integrated supports and access to the community, that there's opportunities to seek employment and really to live a community life just like everybody else and control your own resources, that individuals receive services in the community to the same degree of access as individuals who aren't receiving Medicaid waiver services. So just like everybody else, they're selected from the kind of options for people who do not have a disability, that the services or the settings ensure the individual's rights of privacy, respect, and freedom from coercion and restraint. We optimize initiative, autonomy, and independence in decision-making for individuals who are receiving services. And we have individual choices regarding services and supports and who provides them. So settings rule also, important note from the settings rule is that all services have to meet the assessed and functional needs of the individual, and risk factors that are identified are described in the plan, that we take efforts to minimize them, including backup plans and strategies. So this is in the federal rule, and for Missouri, that means that we have safety crisis plans in place for individuals who might need them because we've identified certain risk factors. Another thing to note is that the behavior support plan is a part of the individual support plan. It's a separate section. It's written by a licensed provider, but it is a part of that plan, and so all of these things must also be reflected in that behavior support plan. More home and community-based settings rule. The individual support plan has to identify who is responsible for monitoring the plan, and if modifications in plan, and when they say modifications, they mean restrictions, so they're modifications from what every other community life is. So if you're modifying this person's support so they're different from typically in the community, then you have to have an assessment that shows the need for that and justify that need in the individual support plan. So let's see what justified means to us and to Centers for Medicaid Services, who we answer to. So there's an assessment that says there is a need for this modification or restriction. You have positive approaches in place, and so in place means used consistently by people who are supporting the individual. That are less restrictive or less intrusive and restrictive methods, and they've been documented in whether you tried them and they failed, or that you're currently trying them, that's being documented. Data has to be collected and regularly reviewed. So that's part of the monitoring. You're reviewing these positive approaches as well as these modifications and seeing if working or if they're still necessary. So we're saying that data should be reviewed at least monthly. That's part of your system already, that you do monthly progress notes. So part of that should be reviewing the positive approaches and the restrictive approaches that are in place to address that need. Might be time limited, so it can't be until they don't do this anymore. There has to be specific criteria for discontinuation. Again, not doing this problem behavior anymore is not sufficient criteria. And our assurances that the team has reviewed these and made careful consideration that these will not cause harm to the individual. So all of these things have to be documented in that individual support plan. So here's a little active review question for you all. What does justified mean in a home and community-based rule? All of the, or circle the answer that's the most appropriate here, and how are they going to do that?
It should have showed up on their screen.
It should show up on your screen, so not circle, but click the answer that's the most appropriate. Okay, 6 people who haven't responded yet, and we are waiting for you to respond. So please indicate an answer. Okay, the poll, and majority of you have gotten it correct. 62% said each and every one of these, and that is absolutely correct. About 4 of you had no answer. Shame on you. We will be having several more of these polling questions throughout, and we are using this to determine if the training has effectively communicated information, so please answer them. So let's move on. So now it's about the home and community-based rule, which is apply individual support plans and our behavior support plans. And Directive 4.300 will be in place until that the behavior support rule that I mentioned is promulgated. It's in process now. It's sitting waiting for review in various places. It's a long process to promulgate a rule. So we are not surprised that it has not happened yet. It could even be as long as another year. It has to go through several legislative processes and governor's office and things like that. So the function of the directive and the behavior support rule is to take steps towards formally meeting those Centers for Medicaid Services requirements and to have them in policy. So they require that we have something in writing saying this is what we're going to do and this is how we're going to do it, and that's the directive and the rule. And it describes the division's policy for reactive strategies, is that we will focus on independent community skills and a teaching-based approach when we're trying to address issues that previously might have been responded to more reactively or more restrictively. That will be focusing on preventing and mitigating challenging behaviors in the most restrictive way possible, in a positive approach, and that we will be, when there are restrictive or reactive strategies, what the boundaries and the ways to use those are. So what you have to do when you're implementing those kinds of strategies. One of the things that I want to be sure that we talk about here is that there are a number of prohibited procedures. These have been prohibited For a very long time. They're prohibited in law and statute, listed in this directive. So are things that have been in place for a long time. As I said, it's things for you all to take note of. In order to train any staff or any team member be aware of it, what these prohibited procedures are. So prone restraints or any restraint up against a wall or pressing a person against an object, we prohibited. Lying on top or sitting on top of a person, hyperextension of joints, any modification or technique from a crisis management system that has not been approved by the division with division-approved training for the implementer. So we're specifying what kind of crisis management system that you utilize, but if you change a technique within that formal system and you haven't had it approved, then that's a problem. Restraints. We'll talk about those a little bit more. Those are prohibited unity-based practices. We cannot use them. Any strategy that might, of course, exacerbate any medical or physical condition or endangers the person's life, interferes with breathing. You can say whenever you need to use XY hold on this person. You can't have a standing order or as you need it kind of basis. We do consider identifying possible strategies that might be used in a safety crisis plan as a standing order, because those aren't when this happens, do this. These are, here are the things that you might consider using when you're in a crisis situation. So it's not a prescription for use a specific procedure. And more prohibited practices. So things that are prohibited are the use of punishment, comma there, so we are not allowed to use punishment in our behavior change or in our individual support plan strategies. We can't use anything for staff convenience or as a substitute for engagement or active treatment or behavioral services. So we can't use punishment as a substitute for behavioral services. We can't use law enforcement or emergency departments as part of how you're going to reduce or eliminate behavior. So if he threatens to throw a chair, call the law enforcement. Use that as your reactive strategy or as your strategy in the individual support plan. It may be that you have to if it meets criteria for calling an emergency department or for law enforcement, but you don't. That's a strategy that you put in the plan. Techniques that are administered by others who are supported by the agency. So a peer cannot administer a reactive strategy. We can't use corporal punishment or aversive conditioning over correction procedures. This is forced exercise or forced repeated actions. You can't put people in enclosed crypts or barred enclosures. Any other treatment procedure or technique or process that would be prohibited by federal or state statutes. So there are a number of prohibited procedures that people should be aware of. So here's the question: which of the following are prohibited in Missouri? Please answer with all of the ones that could apply. So they can do multiple answers, right?
Not on this one.
Okay.
So
pick the top one, because there are multiple answers here. So I changed that question to say which one of these is not prohibited in Missouri. I didn't realize that we didn't have multiple answers available. I'm sorry for that. The only answer that is incorrect is C. So safety crisis management curricula other than Mandtor NCI can be used in Missouri. So the only one that's not a prohibited practice. All of the other ones are prohibited in the state of Missouri. So now let's talk about mechanical restraints. That's something that we have to take a special review process to review these and figure out how to discontinue the use when we discover them. And mechanical restraints are any device, or physical object used to confine or otherwise limit an individual's freedom of movement that can be easily removed. Mechanical restraints are prohibited from use in home and community-based settings. I can give you some examples of things that are not mechanical restraint. This is protective equipment that's prescribed as part of a medical treatment. So just to catch here, you can't go and ask the doctor to prescribe wrist restraints unless the doctor would consider those part of medical treatment for a medical issue. And I'm not sure what that treatment would be or what that issue would be, but it's not enough to have a doctor prescribe it. It has to be for a medical issue. Physical equipment or orthopedic appliances, surgical dressings, supportive body bands, or other kinds of things that restrain a person for routine medical treatment or physical exam medical tests are not considered mechanical restraints. Anything that's supporting the body function or keeping a person from falling out of bed or falling out of a wheelchair is not a restraint. Now, if it's because the person gets out of bed and gets into trouble, you don't want to tie them into the bed. That would be a restraint. If they have no physical control of their body movements and you're helping them to stay upright in a wheelchair, that's not a restraint. Physical equipment used for safety during transportation, such as seat belts or wheelchair tie-downs, and used to keep a person that normally would be used to keep people in a proper balance or body position, would not be considered a mechanical restraint. So that's an important issue. We want to remember that the home and community-based settings rule says that people will be free from coercion and restraints. They'll have free access to places just like everybody else, and that's what we need to be trying to promote. Of course, we need to be looking at safety, but we have to do safety in a way that's not tying a person down or holding a person down. So a reminder for everybody. And now another polling question. Which is probably an example of a mechanical restraint? is an interesting question. My answer for this one was taking crutches away from a person who needs them to walk, taking power mechanisms from wheelchairs, because those prevent people from moving and don't have an alternative once you do that, assuming they need crutches and they need the wheelchair. 53 people put individual special seat belts that cannot be removed by the individual, and I was considering that mechanical, a typical equipment used for safety during transportation, such as seat belts or wheelchair tie downs, and probably the cannot be removed by the individual was the key phrase there that required you all, or resulted in you all putting that it was mechanical restraint. But there are those the safety buddies that we are considering a belt that's a safety device and non-mechanical restraint when used in a moving vehicle or a vehicle that moves. So that's a thing to consider. And about 10 people put in a wheelchair for a person that can't manipulate the wheelchair and the lock. And so if you lock the wheelchair and they can unlock it, then it wouldn't be restraint because they can unlock it and move. And so the explanation about those questions there. Now, on to some steps that are sometimes confusing to folks, and what I tried to do is draw some diagrams to help you to see this. And I think one reason why reactive strategies, restrictive interventions, and rights restrictions, those concepts are confusing to folks, is that folks are expecting them to be black and white, completely separate kinds of things. And as with things in life, they're dependent on context, they're not black and white, and so we have to get used to doing some critical thinking around these kinds of things. As you can see from the diagram, reactive strategies include almost all rights restrictions and restrictive interventions. So almost all of those things are reactive strategies. However, there are some reactive strategies that might not be restrictive interventions or rights restrictions. There are some restrictive interventions that might not be rights restrictions or reactive strategies, etc. So they are related. Sometimes one strategy could be all three, sometimes not. Context is very important. We have to consider the context. The other thing that I want you to be aware of is that the term restrictive intervention is the Centers for Medicaid Services term and definition. So we are using that in our system because it is something that the federal government is using. So let's talk about reactive strategies. Reactive strategies are the use of immediate and short-term procedures necessary to address dangerous situations or problem behaviors that could lead to dangerous situations. People at risk or other people at risk. It includes things like blocking or physical restraints, but it's more than that, or it can be more than that. There even could be some delayed responses. So it might not, a reactive strategy might not just be what you immediately do after that. There could be some delayed responses that are considered reactive strategies, such as restricting access to the community or some kind of increased level of supervision that might take place a little away from the behavior and over a period of time away from the behavior. Basic strategy is used in direct response to some kind of undesirable behavior, as opposed to a proactive and preventative strategy that's used prior to an undesirable behavior, so that perhaps it doesn't happen. So questions that you might be able to ask yourself to help you figure out, is something a reactive strategy? So is this strategy used in response to an undesirable behavior? So you use it after an undesirable behavior happens. If the answer is yes, it might be a reactive strategy. Is the strategy to bring about immediate change in the environment the situation or the behavior. If the answer is yes, it might be a reactive strategy. Trying to reduce risk associated with the behavior, that's a one, because it could be a reactive strategy or it could be a proactive strategy depending on when you're implementing it. So, for example, here's an example of a preventative or proactive strategy. We have individual Joe who has a visual display on his wall of his bedroom that lists out his behavioral expectations, the things that he has to do in order to earn a preferred reinforcement. And before something happens, like going out in the van, staff pre-instruct him on what his expectations are and what he has to do in the van in order to, and these are things that are based on his need for structure and for increased comfort, and things that he needs to know about the outing. So doing this instruction, they use things like validating his feelings. I know you get kind of anxious when you don't know what's going to happen. I know you're really excited about the outing today because you're going to get to see your best friend. What kinds are you going to do with your friend? That's an open-ended question. They use some of the tools, choice strategies like stay close, random, and routine, or even stay close hot if he starts to get a little bit of upset. Those are all strategies that might be used towards going in the van. So they are respond to behaviors that have occurred in the past but aren't expected to occur, or hopefully aren't going to occur right now, and they are trying to keep him safe and do the right thing. And they might even set up in this proactive process a cue to Joe, like, I'm going to say to you, remember, you need to stop and think. I'm going to try to say it real quietly. We'll see you starting to get upset or whatever his issue is. None of the only one that's really a reactive strategy is that prompt, I'm going to see you stop and think, the reactive strategy. And the rest of these are proactive and not restrictive strategies. That although if in the situation he starts to get upset and you use what we call or empathy or stay close hot during that situation, you say, oh wow, I see you're starting to get really anxious. What can we do to help you calm down? Remember, you need to stop and think. If you do that would be a reaction to the behavior. That's not a restrictive strategy, just a reactive strategy. Let's see. Here are examples of strategies that you might use after a undesirable behavior. So all of the ones that you would consider a reactive strategy.
We have been, in entering these questions, the polling feature, we have a choice for single response and multiple response, so I've been working to set those to multiple. For those that don't, that doesn't apply, I'm trying to work that out on my side, so Dr. Rogers will address the responses. Technology is working with us.
Multiple answers here, and actually, I think all of these could be, and some of them definitely are always reactive strategies. Some of them could be reactive strategies depending on when they're used. So if I would have put the easy answer of all of the above, you might have answered that. Most of you are choosing amongst all these, so good job. So let's move on. So we've talked about reactive strategies, and now talk about restrictive interventions. So remember, this is Centers for Medicaid Services definition for restrictive interventions, and a restrictive intervention is an intervention that restricts movement, access to other individuals, locations, activities, or personal objects. So if you're wondering, is this a restrictive intervention, you would ask yourself that. Does it restrict movement or access? It might also ask, is it an intervention, is it an intervention that restricts rights? Because then it might be a restrictive intervention. Or if it employs aversive methods, it might be a restrictive intervention. So that's a little bit of a mind teaser there, because remember, the community-based center services rule says that people are free from coercion and restraints. So aversive methods are coercive methods, and so if you use those, they're not free for them, and it would be a restrictive intervention. And so I think that's like a double negative kind of thing there, but that's how that applies. So is it restricting movement or access to things that people typically have access to, including their rights? So that's when we're talking about restrictive intervention. And looking for my page here. Okay, so yes, so ask yourself these questions: does it restrict movement or access, aversive or coercive? And answer yes for each of these that you would consider a restrictive intervention. And then answer a question that came in. Okay, so here for does it restrict movement access? Is it a restrictive intervention? Would be all of the interventions. So because it's restricting access to things that we all typically have access to. So most of you are allowed to go places places where there is food available. Most of you don't have a restricted list of places that you're allowed to go. So timeout is a restrictive intervention because you're restricting movement from a location. Most of you have access to all of your clothes and possessions. You're on a smoking schedule, but nobody else is putting you on a schedule and requiring you to stay on that schedule. Most of you have access to most of the areas of your home. So those are kind of the parameters that you want to think about. I have a question here that said, what do you do about somebody who is being violent with their roommates and you have to restrict access to other consumers? Okay, so I want you to remember there are prohibited practices. These are things you may not do in home and community-based service, actually in services at all, because they're prohibited beyond just home and community-based services. Those prohibited practices, that's not what we're talking about here. We're talking about reactive strategies and restrictive strategies. You may have to do these. It may be the right thing to do to use several of these or one of these. So if you have to maintain safety, you may have to use a reactive strategy that's restrictive in order to do that. So you may have to move the person or move other folks away from that individual. So don't confuse with prohibited practices and reactive and restrictive strategies. They are completely different. So these are going to be talking about what are reactive strategies, restrictive interventions, rights restrictions. What do you have to do in order to use them? You have to identify need. You have to have all of the positive strategies in place. You have to take data. You have to review data. You have to have it time limited. All those things have to be in place. You're going to utilize these kinds of strategies, but you can't too. So just a little reminder there. That's a very good question. So then we have things called rights restrictions. A rights restriction is a kind of reactive strategy, possibly, or restrictive intervention that places a kind of limitation on any of the general liberties that we all have available to us. So any of the things that you can do, that you have the right to do, if it's limiting that, it's a rights restriction. It limits freedom of movement because you have freedom of movement. If it limits if it limits choice, if it limits communication with others, so not allowing people to call certain folks or use the phone, those kinds of things to people, that would be a limit in communication. Is it limit leisure activities or personal property, access to money, parts of the community or the home, then it would be a rights restriction. Does it limit any of the rights that are assured to clients of the Department of Mental Health or assured to citizens of the United States or the world? The other thing that we want to remember is that and our philosophy in general in providing supports to people with developmental disabilities, to all humans, is to promote dignity and respect and utilize least restrictive strategies and have a least restrictive environment. So if you are doing a rights restriction, you still want to make sure that you are promoting dignity and respect and doing things in a least restrictive way. And if it doesn't, it's even beyond a rights restriction. It's probably even more problematic than that. Support teams need to consider these things when they're thinking about strategies that they'll be putting in place and training staff to use them and writing up some behavior support plans. And rule, the rule tells us about those rights restrictions and it tells us what we're going to have to do about them. But first I have a little polling question. So answer the following that you would consider a rights restriction or indicate restrictions. Okay. So most folks indicate that ones of these, and this is another one of Terry's trick questions, because they're all possible rights restrictions. So not many of us would stand allowing these things to happen to us without a lot of caveats and control around it. And there are things that we typically do with individuals we support that are problematic. They are rights restrictions. And so when things are considered a rights restriction, there's a whole lot of other stuff that you have to do, which is ensuring formally the home community-based settings requirements are in place. And the process part of what you have to do, you do those at the support team level, at the writing of the strategies level, at informing the individual, choosing your strategies, and then you have to go through a due process review committee, which is only reviewing to see what due process offered. So it's not an approval committee, it's just a review, a second look to see that the support team has done due process. So they're about rights restrictions. And the reason that you want to know about reactive strategies and rights restrictions and restrictive interventions is because it's not the way that we want to, that's not the main and only approach that we want to take. It's not the reason for writing behavior support plans. If you have to use these, then there's things that you need to do to make sure that they're working. That's that data review. And we have put in place through this draft rule and the directive a formal process that's required by the support teams. So this is the individual team supporting an individual. If in the course of supporting an individual, you are finding yourself using reactive strategies frequently, and I'm going to be mainly focusing on those reactive strategies that are also restrictive. You might use validation or empathy or stay close hot if you know the tools of choice a lot with an individual. And I would say if you are using it times a week and daily, that you probably need to look at what's happening, and either they're in a short-term crisis or something's not going right, so you probably still need to think about this. But if you're using restrictive interventions that are reactive strategies, then have a threshold that you need to pay attention to. The support team. As a support team, we have identified a lower threshold that if you meet this, you want to do something else. You can't keep going on like this because you're going to end up in a problem situation. So this is trying to get to become more proactive in their approach and look what's happening. Yeah. Question: Do you have to wait for the rights restriction to go through due process before you implement it? So this is like a trick question to me, because going through due process is what happens at the level of the support team. That's you all doing the assessment to say you need it, you all identifying what it's going to be, a data collection procedure for how you're going to evaluate that you are using it and that it's still needed, that you have positive strategies also in place, that and also identified the least restrictive interventions. You've informed to the person, you've got consent. All of that is the due process, and yeah, you have to do that before you use the strategy. Going through the due process review committee is not due process. That's the second look at has due process happened. It's not as simple as it seems, because it's due process is that thing you do while you're figuring out and setting up using the reactive strategy or rights restriction, and you have to do that. Okay, reactive strategy threshold. If you saw an original draft or previous directive, used to be not related to restrictive intervention reactive strategies. It just was reactive strategies, and it used to be 3 or more within a 6-month period and or 2 or more in a 2-month period. But in viewing this with some and support coordinators and discussing how this was being interpreted, we found that that was too narrow a description or too broad a description, and we need to narrow it. So we have narrowed that to reactive strategies that are restrictive interventions. If you use 5 or more within a 1-month period, then that's reaching the threshold. The threshold is 5 or more reactive strategies that are also restrictive in a 1-month period. So what do you have to do if that happens? Good question. So if that happens, if you reach that threshold, there are some things that you need to do. If you reach that threshold for 3 consecutive quarters, the planning team must refer the individual and go to the Regional Behavior Supports Review Committee for consultation. So the planning team, the support plan, the data around it will refer to the Regional Behavior Support Review Committee if you reach that reactive strategy threshold for 3 consecutive quarters. That reactive strategy threshold for 3 quarters, not consecutive, in a 2-year period, then you must request behavioral services. So you may end up requesting behavioral services in both cases. You may end up going to the Regional Behavior Supports Review Committee in both cases, but we'll have them specified. We want a more immediate reaction if you've got 3 consecutive quarters, and we want you to behavioral services or at least request behavioral services. I know there's a shortage of service providers and access to services, but you still can request them, and that can be formally noted, and we can establish need and that the team is aware of this. So that's part of what happens when you reach that reactive strategy threshold. So here's one of my polling questions. When the Directive 4.30 mandate behavioral services, which one of these is the answer? It was a little bit of a trick question. Although there is a correct answer there. The correct answer is A. We don't actually mandate behavioral services. We mandate that you request behavioral services. So we can't mandate or we can't give you access to something that may not be available, but we can mandate that you request it. That's what we've done. After 3 or more quarters in a 2-year period, that you have to request behavioral services. So the answer is A. So I'm going to pause just a minute and see if there's any questions from you all. Type them into your Q&A box if you have any questions about the material so far. Then we're going to go into seclusion timeout. So do you have any questions? Okay. Question, how would you handle treatment of the consumer who wants to smoke but their parents do not want them to smoke? The parent wants to include this in the behavior plan. The consumer is their own guardian and they live independently. Or your own guardian. And let's just assume that your parents don't want TV or your phone, okay? Your own guardian, you, who you right now, and you're a professional in the community, and your parents say, I want you to use a cell phone. Do. I'm using a cell phone anyways. Maybe have a discussion with your parents saying, I really have to use a cell phone because I live in this world and have this job, and, you know, what is it that you don't like about the cell phone? I can not use it when you're around. That'd be polite. I can not use it at the dinner table. So you have a discussion like that. This individual is their own guardian, and they live independently. I don't think any more about that. You can facilitate a discussion with the parents, but we're certainly not going to put that in the behavior plan. We don't have the ability to do that. It would be against our law to do that, or against our rule to do that. So it sounds like the parents and the individual need to have a discussion. Can provide behavioral services prior to the use of reactive strategies. Okay, I'm hoping you can hear this. Yes, please do. What we have to do is make it obvious to folks when they absolutely should do this, but you absolutely can do it prior to this. Absolutely, that'd be a great idea. Please, whenever you think that you might. If you have somebody who's having trouble learning, if you have somebody who's starting to bubble up, you should look for help to make things better in that person's life. And it might be behavioral services would do that. I'm biased. I think they probably would. But yes, absolutely. You don't have to wait for it. So let me explain to you. We create rules and regulations and laws are written for the outlier who's not going to do what they should do anyway. And so they're written for those of us that would do what's like right or just are honorable. They're written for the folks outside that boundary or folks who don't know what to do. So yes, you can do it beyond that. This isn't you can only do that. This is you do it when. You can also do it at other times. Only restrictive interventions that are reactive strategies need to be tracked for data purposes. No. Any considered modification to how typical people live in the community, all the rights, all things that happen for typical individuals, anything that's a change from that, that's modified from that, has to have all things that we said involve justified. You have to have an assessment, you have to have positive strategies, you have to have data collected, you have to review that data, it has to be time limited. All of those things have to be true for any modification, not just restrictive interventions that are reactive strategies. The question is, PowerPoint. Yeah, the copy of the PowerPoint will be available, and also this recording will be available. And let's see, I have questions. Some other questions are, how long an approved behavior support plan be implemented? Is it only for 1 year? This recently told to us by an agency that develops behavior support plans. So remember, behavior support plans are part of individual support plans, and individual support plans have to be reviewed frequently and have to be at that annual review and of those plans has to happen. However, both of these are living documents, which means that whenever they need to be changed, they are changed, and we don't wait for the annual time to do that. There are amendments made, and we make changes as the data and the situation requires. What that we're considering behavior support plans is that these are prescriptions for treatment. And these prescriptions for treatment are only good as long as you're under the care of the professional who wrote the prescription. So behavior support plans can't be in place after behavioral services are discontinued. What behavioral service provider needs to do is hopefully figure out those things that are necessarily part of a behavioral service plan to typical support strategies, and those typical support strategies can then be written into the individual support plan, and the behavioral services can be discontinued. Though, the behavior support plan and the individual support plan and any assessment are property of the individual, not behavior service provider, not of the support coordinator, not of the service entity. These are property of the individual. So copies of these need to go to the support team, to the support coordinator, and the individual. And be available in history, in the future, historical documents, and so they need to be available in the future, and they cannot be the behavioral service provider, so they have to be available to everybody. Another question is, are locked doors on the home to keep individuals from wandering out unsupervised at night considered restrictive intervention? So this is a very good question. So most of us, and especially those of us who live in cities, lock doors at night to keep people out. Some might lock the door to keep people in. If I'm locking the door to keep people in, I assume that the people I'm trying to keep in can't unlock the door and go. If I can look at my restrictive interventions questions, the questions are, is it keeping, restricting movement and access to the community? The whole reason for it, I'm locking the door to keep people in and restrict access to the community. So in this case, it would be a restrictive intervention. I have to look at what's the purpose of it, and can the person, if the person can unlock the door, then it's not a restrictive intervention because they can unlock the door and walk out. So it is a restrictive intervention. Okay. The next question is, this presentation is part 1. Will you have others to cover the rest of the directive? Yes. Part 2 of this training will be on the 25th. A separate sign up for that. The question is, are there specific limits to the number of hours a behavior analyst can provide to an individual in a year? That's an interesting question. There are 13 services that are applied behavior analysis services, and each one of them have a maximum limitation. Yes, there are limits to the number of service hours provided depending on the requested. I have a question about record being kept for 5 years. So you look at the Medicaid guidelines and the Medicaid waiver guidelines. It might even be 7 years, but that would be something that I would check directly and not take Terry Rogers' word for it, because that doesn't hold water in the courthouse or in the CMS when you say, well, Terry Rogers told me. You want to check that out, but I believe it could be as long as 7 years. All right, I think the questions that nope, there's more. Purposes of the reactive strategy threshold are strategies that are part of a BSP, that are BSP if the individual already receives behavioral services. All right, I'm not doing that right. Let me read it again. So I think the question is, are within a BSP considered reactive strategies? Yes. If they meet that we're talking about, these criteria that we're talking about, if they're in a behavior support plan, they'd be considered reactive strategies. I don't know if the email for session 2 has gone out yet.
No, that I believe is scheduled to go out tomorrow.
So that's coming. All right, if there are no more questions, and I will give you another opportunity in a few minutes to ask questions, we're going to go over one more section of this directive and draft rule, and that's the section on seclusion timeout. So seclusion timeout, and the definition is very important. There's some important words in here. Seclusion timeout. This is involuntary confinement of an individual alone in a room or area from which individual is physically prevented from leaving or contact with others for a period of time that's not determined by the individual. So there are several critical elements there. Involuntary confinement, alone, in contact or leaving for a time period not determined by the individual. So that's 4 major elements that are important. Seclusion timeout, if you do get permission to use seclusion timeout, that lock has to be the kind of lock that is able to be walked away from and still be locked. So in other words, it has to be a staff secured lock. It requires somebody being there actually physically manipulating a mechanism in order to keep the door locked. So you can lock a door and walk away. You can call seclusion timeout whatever you want. You can call it the marshmallow huggy swirly room if you want to. If it meets those 4 criteria up there, it's seclusion timeout. So I don't care what you call it. It's seclusion timeout if it meets those 4 criteria up there. This has been in place since January of 2015, so that's just something for you all to note. It's not a new thing. And next slide, some responsibilities of the service coordinator or support coordinator with respect to seclusion timeout. So support coordinators are kind of advocates and safeguards for the individual, and so they should be paying attention to and noting that you may not use seclusion timeout unless all of the following conditions are met. So they want to, if they see something that looks like seclusion timeout, they want to take a moment to see if all these things are met and get some assistance if they appear not to be met. And the person that I would go to in that situation would be the area behavior analyst. If you think that a situation is occurring that looks like seclusion timeout and all the necessary requirements are not met, or have any concerns about behavioral services or the way somebody's supported, you could go to the area behavior analyst. However, seclusion timeout requires that there be a qualified behavioral service provider involved with the team during the whole time that seclusion timeout is as a strategy in place for that individual. That service provider has to complete a functional assessment that then the results of which indicate that seclusion timeout would be a reasonable intervention. The behavioral service provider has to complete a behavior support plan. A plan has to be approved. This is one of the times that the Regional Behavior Support Review Committee does approval by the Behavior Support Review Committee. Said they have to be providing ongoing services. In addition, Chief Behavior Analysts have to review that seclusion timeout plan prior to it being implemented. So those are the requirements for use of seclusion timeout. And again, there's 4 things that make something seclusion timeout. We have that in the definition. Okay. So responsibilities of the regional office when there's seclusion timeout includes that it's reviewed by the Due Process Review Committee and that it is reviewed by the Regional Behavior Support Review Committee. If any time we discover that seclusion timeout is being utilized without approval, that's a prohibited procedure if it hasn't had approval, or any other prohibited procedures are discovered, like mechanical timeout, then there's a special review process that we have to follow that's identified in the directive. So we have to have a process where we go on site, we look at, see what's happening, we interview various people, we look at the data. We notify quality assurance. We notify licensure and certification. They have to do follow-up reviews, and we meet with the team to correct the situation. So to stop using any prohibited procedure, do something that's more appropriate, or if seclusion timeout is necessary, to go through the process of getting all the things in place to be able to use seclusion timeout. So that's the special review process that we have to do if we discover any of these prohibited practices or use of seclusion timeout without the approvals. All right, here's a test question for you. These, A or B, is an example of seclusion timeout. Go ahead, Nick. Okay, so the answer is A. There's 4 criteria that have to be in place that make something seclusion timeout. Joe's been trying to bite staff and his housemate while everyone's in the living room watching TV. Staff escort him to his bedroom, require him to stay there, and close the door and block him leaving. So he's moved to a different place. He stays in his bedroom. They close his door, block him from leaving. So that is the answer of which one is seclusion timeout. B is not seclusion timeout because staff remain with him in the area until he's calm. So they do move him to a separate area, but he's alone in that area. They're not physically walking there, and they stay with him until he's calm. So that one is not seclusion timeout. Okay, that is the information that I have to present in Part 1. Tune for Part 2 on September 25th. The regimen will go out. It's at 8:00 in the morning. And if you have any other questions that I haven't answered about the information in Part 1, I'll stay on for the next few minutes to answer those questions. So write them in the Q&A box and I'll answer those questions. Have a question, let me see if I can answer that. Teen ABA services. This would Medicaid waiver. All of the waivers have those 13 services. There are 4 functional assessment services and then 9 the functional assessment services, and those are all in the Medicaid waiver. And actually, I say that it's going to be a draft waiver, not the waiver that's in, from the CMS website, because that one is behind in being updated. So that should be available in the Medicaid waiver. You can also go onto our DD website and look in individual supports, the behavior supports, and you'll find some information about those services in that site also. And let's see.
I'll take on 9/25 at 10 a.m. I'm guessing that's on the upcoming webinar page. We'll take a look at that, and if it still says Part 1, we'll make sure that's changed to Part 2.
I couldn't get a clear answer from the BAB. Do RBTs need to write session notes? We are billing Medicaid. Every service that's provided needs to have notes for every date or session of service. Every unit of service needs to be covered in a progress note. So, and that, because it's a registered behavior technician working under the licensed behavioral service provider, those licensed behavioral service providers need to review and sign off on each of those notes. So I would say when in doubt, write a progress note, because otherwise, if there's no documentation, you could be in a payback situation. My answer would be yes. Will there be training on conducting functional assessments, completing it, and also a training on creating behavior support plans? I think that's graduate school. You need some assistance. There are lots of continuing education opportunities out there for learning to do those kinds of things. We'll, in the second session, go over some things that are required in behavior support plans. You might contact the regional or the area behavior analyst and attend a regional behavior review committee to see what kinds of things they're looking at in plans, and that will help you in designing behavior support plans and writing them. And I have is, does this apply to self-directed services, supports by children, for children by parents? So this applies to any service that is funded the division by Medicaid waiver, by Medicaid. So when a parent's just being a parent and doing parenting stuff, then you know, want to be abusive, but we're not paying for that service. We don't pay for a parent service. But they are acting as a can't think of the word, an assistant or being paid for it, then these things would apply. Where can I find the draft waiver? Mark, I'm going to get you to give me your email so I can follow up with a link on that. It's on our website, but I can't pull it out of my head right now. I have a question from Allison about registered behavior technicians, and they complete a data sheet. That's good. You get the requirements for documentation of services in the Medicaid waiver and make sure that that data sheet meets those requirements. Stephen asks, can direct support professionals record weekly data on reactive strategies using a tracking form? Can direct support record weekly data on reactive strategies using a tracking form? Sure. Remember, really looking at, for reactive strategies, threshold is reactive strategies that also are restrictive. So I want to consider both of those things. But sure, they can do will there be discussion about individual support team roles when developing a crisis safety plan? So there is a separate training on crisis safety plans, and we'll touch on it a little bit in part 2, but there is a separate training on crisis safety plans. It's available in our webinars, and you might look that up. The role in crisis safety plans is vital. They are part of developing that. It can't be without them. So you will want to pay attention to that in that the training that's available on crisis safety plans. Any questions that you all have? We've got a few more minutes. Okay, so I have some questions. Okay, we were told that this would give staff a guide to the behavior planning process. Section cover those. Sure what crisis behavior planning process is. Maybe it's the crisis safety plan. You really want to know in depth about crisis safety plans. You'll want to look at that crisis safety plan training that's available on our website. Between seclusion, timeout, and telling someone to go to their room. So that's a question. In general, because the folks that we support are dependent on us for so much, for transportation, for their food, for clean clothes, for socialization. They're dependent on us for so much. I mean, it's to be their home, and if and they're supposed to choose it, and they're supposed to choose their service providers, but in reality, it seems to function a little bit different than that. And when a service provider gives notice, the person has to move. And so there's a lot of control inherently involved in our system right now, and that's something that we really need to move towards changing. But because it's so inherently involved, that we're so in control of their environment, there's a big element of implied coercion there. That's one of the reasons we need to change this. I mean, when a service provider gives notice, the person should be able to keep their home, and the service provider moves on. So, you know, because there's that threat of no access to food, no access to socialization, no access to I could dump you, you'll have to move, because all of that threat's implied there, saying go to your room as good as physically escorting somebody to their room. Now, our definition says physically blocked from leaving. So what I would say is what they don't go to their room, what happens? What is the room, but they come out before, you know, our staff going to make them go back in until they are told they can come out. So these what ifs are important because answer that question of do they have to stay there and are they blocked from coming out, and can they make that decision on their own? And so, you know, you could have a process of somebody going to seclusion timeout where nobody lays hands on them. I don't know why you're using timeout in that situation, because if they're client with going to their room and staying there, I'm not sure you need timeout, but that's another question. What about when hospitals use restraint like post-surgery? So you'll want to remember that mechanical restraint definition that says if it's for a medical procedure or part of a medical process, then it's not a mechanical restraint. And none of us are hospitals. What do they have their own regulations around? It's looking at what we do as part of our service providing that we consider mechanical restraints. When hospitals hold people who shouldn't be in the hospital anyway because we dropped them off at their door and forced them to take people, and they end up putting them on a medical ward instead of a psychiatric ward, and in order to keep people safe and that person safe on that medical ward, they tie them down. I wish we considered that the service provider and the guardian do mechanical restraints, but we don't. So that's on the hospital, and they are jeopardizing their license when they do that. So when it's done in the hospital, it's not mechanical restraints, the short answer. But when do I have the short answer? All right, the regional safety planning teams. A couple of concepts into there. We don't know safety planning teams. We're talking about who writes the safety crisis plans. That is the individual support team, and so it could be whoever the individual wants on there, the service providers, the service coordinator, those kinds of folks are on the team that writes those safety crisis plans. And we're talking about the Regional Behavior Support Review Committee. Those are made up of volunteers who are behavioral support providers in the community. So this is very specialized team of folks who volunteered to provide consultation to people in the community around behavioral supports, and they're all licensed behavioral support providers. If you're interested in knowing more about those, please contact your area behavior analyst in the St. Louis area. There is that is Melantha Witherspoon. In the central Missouri area, that's Lucas Evans, and in the western area, that's Rita Cooper. Those folks are chairpersons of that Regional Behavior Support Review Committee. And the last question is, will there be a survey at the end of the session? And as Heike mentioned at the beginning, there are surveys at the end of each of these, and we really appreciate your feedback on those surveys. So as we sign off, please complete the surveys. Thank you all.